Good morning, everyone. This morning, Dr. Emmanuel Taban is presenting to us, and he is a highly qualified registered pulmonologist and also holds a European Diploma in adult respiratory medicine. To imagine that he actually started uninterrupted schooling at the age of 17 defies all logic. Dr. Taban also emerged with a novel technique of mucus extraction from the lungs in the midst of COVID-19. He is also the first doctor in the world to undertake this intricate procedure. And today, Dr. Taban will present to us the topic of sarcoidosis, the greater mimicker, or is it the ultimate chameleon? Thank you, Dr. Taban.
Thank you, Michelle, for the introductions. Let's start. All right, so we're going to be looking at sarcoidosis at quite fitting. Just overview. Sarcoidosis is a multisystemic granulomatous inflammatory disease. Predominantly, it really affects lung and lymphatic system, and variable clinical cause can be self-limiting to progressive fibrotic disease, and there's the definitions is a multisystemic chronic inflammatory disorder of unknown etiology characterized by formation of non-cascading granulomas. Let's look at the epidemiology of sarcoidosis. Of course, it's a global disease with ethnic and geographical variability. Increased prevalence since 1990. Age distributions is bimodal, peaks at 20 to 40 years, and women more than 50 years. Ethnicity, which play a quite big role, is a high prevalence in African Americans and Scandinavians. In South Africa, we've also seen quite among Black patients, quite high number, having 3 sisters that really got all with sarcoidosis. So I think the number for quite very high prevalence among Africans actually than what we thought. Maybe we need more studies for that. Genetics, there's slightly higher incidence and severity in females. What's the pathological hallmark of sarcoidosis? Of course, it's non-cascading granulomas, dysregulated immune response, persistent inflammations, leads to organ damage. Genetic susceptibility. Why certain people develop sarcoid while others not? Of course, it lies really on the human leukocyte antigen DRP1, which is normally linked to Leffler-Green syndrome, and that's more common since Scandinavians. And then, of course, the BTNL2 gene implicated also as part of the genetic susceptibility, and HLA association, strong link to HLA, DRP1 alias. Of course, the risk 3.7-fold increased risk in first-degree relatives of affected patients. As I said, I got 3 sisters, all with sarcoidosis. Environmental occupational triggers. Of course, you have we've seen that a lot with silica, beryllium, organic dust, and then we've seen a lot of mine workers, firefighters, post 9/11 exposure, and farming and biomass exposure. Those play roles as environmental triggers. Infectious hypothesis was mycobacterium tuberculosis DNA detected in granulomas in patients with sarcoidosis. Remember, it's a DNA, but it's not actually the PCR to confirm that there's TB and the sarcoid. No, it's just a DNA that was picked up. And then also there's mycobacterium acnes, frequent also identified. And the relatives that infections. Okay, infections likely act as immune triggers rather than direct cause of the sarcoidosis. Let's look at the immunopathogens of sarcoidosis. Of course, it's clear that the environmental triggers and genetic triggers without antigen processing. And then, of course, you get MCH, which is a major histocompatible complex class of molecules, present the antigen to CD4 T cells. And then you lead to the activations of CD4 cells, and there's impaired in the Treg response. So that means they can really read the CD4, and that results in unchecked production of interferon gamma and TNF alpha and granuloma formation. Just for the fellow, I want to look at the really immune system in more details. Let's look at the roles of innate immune system. So the role of innate immune system in sarcoidosis is an initial immune triggers. Sarcoidosis is initiated by an innate immune response to poorly defined antigens via pattern recognizable receptors, they toll-like receptors, and also node-like receptors. They play key roles as triggers. Alveolar macrophage, of course, is central effector cell. Normal so M1 polarizations, which I'll discuss later, and increased antigen presentations and production of TNF-alpha, IL-1 beta, and IL-6. This is really a potent pro-inflammatory cytokines. Dendritic cells, which enhance maturations and migration, drive the CD4-TH1 activation and granuloma formation. Inflammasomes activations with NLRP3 inflammasome promote IL beta release, sustaining granulomatous inflammation. Genetic susceptibility, there's polymorphism in toll-like receptor gene, BT, NL2, and NOT-like2 genes influence innate immune activation and disease risk. Clinical implications of the innate immune system, of course, lead to dysregulating innate immunity, underpins granulomas formation, supports steroid responsiveness, and represent a target for TNF-alpha and noble immunomodulators. What about alveolar macrophage? Just quick overview of alveolar macrophage. Alveolar macrophage, of course, is differentiated from the monocytes. And differential rate takes place in three forms. If the monocyte being stimulated by interferon gamma, and they produce what we call M1 macrophage, which is a pro-inflammatory cytokines and secretes factors such as IL-3 and TNF-alpha. IL-4 and IL-13, you get M2 macrophage, which again, and then they produce IL-10 and TGF beta, which is what we call anti-inflammatory or pro-fibrotics. And then, of course, the last one is tumor-associated macrophage. That's really probably not, which also play a different role in immunosuppression. Alveolar macrophage in nut cells, of course, as I say, it's a central effector cells. Increased numbers and activation in bronchoalveolar lavage and lung tissue is a key drivers of granulomas formations. Pro-inflammatory polarizations, which is M1, stimulated by interferon gamma and TNF-alpha from the TH1 CD4 cells. Produce TNF-alpha, IL-12, IL-1 beta, sustaining granulomas inflammations, and hence a response to steroid. What about the role of ACE and vitamin D metabolism? Macrophages produce angiotensin converting enzymes and express 1,2-hydroxylases and increase calcitriol and thus hypercalcemia. So antigen presentations is upregulating MSC class 2 expression, promote activation and expansion of CD4 T lymphocytes. Inflammasome activations and LLRP3 activation increase IL-1 beta and amplify inflammation. IL-1 beta is also a potent inflammatory cytokines. Clinical relevance, of course, TNF-alpha blockage effective in refractory disease, which can be used in patient refractory sarcoidosis, and macrophage activation correlates with PET-CT uptake and active disease profile. Immunopathology. Now, if you look at the more close look at the M1, which is your pro-inflammatory, and M2, which is really anti-inflammatory. The macrophage immunomodulatory sarcoidosis. M1 macrophage, which is a pro-inflammatory, dominated early and active sarcoidosis, driven by interferon gamma and TNF-alpha from TH1 CD T cells, produce IL-12, IL-1 beta, TNF-alpha from granuloma formation, and associated with the PET-CT positivity and active alveolitis. M2, which is a pro-fibrotics, of course, increase in chronic fibrotic sarcoidosis induced by IL-4, IL-13, and IL-10, promote tissue remodeling, collagen depositions, and fibrosis. Express markers such as CD163 and CD206. Dynamic polarizations, sarcoidosis reflects a continuum, not a fixed phenotype. Shift from M1 to M2 switch, linked to disease chronicity and fibrosis. Clinical implications, M1 predominates, that's a patient with early disease, the steroid responsive inflammatory disease. While if it's M2 predominancy, you'll get a steroid-resistant fibrotic phenotype, supporting rationale for targeting immunomodulatory therapy. Now, to make a diagnosis of sarcoidosis, we need evidence-based diagnosis of sarcoidosis. So to make a diagnosis, obviously looking for the diagnostic triad, you need to have a computable clinical presentations, supportive radiological findings, and histological evidence of non-cassating granulomas. And then, of course, you need exclusion of alternatives, mandatory exclusion of tuberculosis, fungal infection, lymphoma, and other granulomatous disease. Imaging, chest X-ray, hydrogen CT, so typical patterns with bilateral hilar lymphadenopathy, perilymphatic nodules, PET CT, useful for active disease and occult sites. Tissue conformation, of course, currently EBUS or transbronchial needle aspirations yield about 80 to 90%. And of course, transbronchial lung biopsy recommended as first-line invasive test. So really the role of mediastinoscopy, video-associated thoracoscopies are now being really, it's no longer as significant as previously. Supported tests, of course, bronchoalveolar lavage, lymphocytosis with CD4, CD8 ratio more than 3.5, elevated ACE or calcium may support diagnosis, but are not diagnostic. Guideline position, of course, diagnosis is multidisciplinary, integrating clinical, radiological, histologic, and microbiological data. Let's look at the clinical presentations. Of course, you have the first clinical presentation is Lofgren syndrome, which is more common in the Scandinavians, and normally, and also I think Asken Jewish also present the same, and present with a triad of erythema nodosa, chest X-rays, evidence of bilateral halanopathy, and musculoskeletal. So in erythema nodosa, which is a tender erythematous indurated nodules, or frequently obtained on the anterior lower legs and sometimes forearms. Chest X-ray or CT, you see bilateral hilar adenopathy, frequently showing the 1, 2, 3 signs, bilateral hilar and right paratracheal lymph nodes. Musculoskeletal, of course, will be swelling and pain in the ankles. And this is really how you look at it. This is your 1, 2, 3 sign, or known as Carl signs. And of course, if you look at your erythema nodosum, this is the lesions just on the chin of the legs. And your one thing, this is really your lymphatic section than anything else. And then, of course, the Selberg's classification system for pulmonary sarcoidosis. These are really gurus that really involved previous in the classification diagnosis of sarcoidosis. So the stage is really into 4. You've got stage 0, where there's normal chest X-ray, no evidence of disease. There is stage 1, you've got bilateral adenopathy with no lung parenchyma involvement. Stage 2, bilateral adenopathy with lung reticular parenchyma opacity. Stage 3, you have lung involvement without adenopathy. Stage 4 is a fibrotic stage. Now, this is really a sarcoidosis presenting, which is a multisystemic disease. Any lymphatic organ can be affected. I need to look at quite a few of these 2 topics in sarcoidosis, just to have a look. One is the ocular sarcoidosis. Those who follow Medscapes or sometimes quiz online, you will see that they will ask the most important question was saying, what's the predominantly of the eye involved in sarcoidosis? They give you option of posterior, anterior uveitis. And the answer really anterior uveitis, which is the most common presentations in patients with sarcoidosis. And this is really, it may be a granulomatosis with matin fat keratinic precipitate. That's followed by intermediate uveitis and then posterior. So actually uveitis is very anterior, intermediate, and posterior, but the common is anterior really. And the reason for that rationale to really understand that because those patients, unfortunately, that if they are not addressed, those patients tend to lose their eyesight. That's very important that early detection that anybody that is suspect having sarcoidosis should be referred to ophthalmologists to have a proper evaluations and start on the steroid, and you can actually reverse the eye issues. Cardiac sarcoidosis is the second one, again, which is most clinicians never really pay attention to it. And this is most of these patients actually, unfortunately, develop sudden cardiac death. And I think 2-3 years ago, we have one of the patients with the cardiac sarcoid, and actually she underwent cardiac transplant at Milford Hospital. So cardiac sarcoidosis is a very serious condition. So clinical evidence, only 5% of sarcoidosis patients The clinical involvement may reach up to 20 to 25% on imaging. Clinical manifestations are conduction abnormalities, arrhythmias, heart block, ventricular tachyarrhythmias, and heart failure. Diagnosis, you need a cardiac MRI with a late gadolinium enhancement identifying myocardial inflammation or fibrosis, high sensitivity and specificity. PET-CT detects active inflammations, guide biopsy, and treatment response. Endomyocardial biopsy, low sensitivity, reserved for uncertain cases. Prognostic markers, extent of myocardial, late gadolinium enhancement, ventricular dysfunction, and arrhythmia burden predicts outcome. So treatment, of course, corticosteroid remain as a first line, and immunosuppressors such as methotrexate, azathioprine, for steroid sparing or respiratory disease. In ICD, placement for high-risk arrhythmias is very important. I'd say that Dr. Lowe, always our cardiologists, tend to quite interfere quite earlier if they got a lot of dysrhythmia. Lung function patient with sarcoidosis, lung function finding, of course, normal lung function up to 30 to 50% of patients, especially early or stage 1 disease, have normal lung function. And that's where the problem comes in, because got normal lung function, most of the time the disease is underlooked. Restrictive disease pattern, which is really more common in stage 2, in stage 4 and 3. Most common abnormality, decrease in FVC and decrease TLC due to parenchymal involvement and fibrosis. Obstructive patterns seen in airway involvement with decreased FEV1 and FVC ratio, air trapping, and mosaic attenuation on horizon CT. And most people tend to confuse our diagnosis of HP. Reduced DLCO, more sensitive parameter of chronic interstitial disease or pulmonary vascular involvement or fibrosis. Mixed defect, combination restrictive and obstructive pattern in advanced or chronic disease. So prognostic value, progressive decline in FVC and DLCO predicts poor outcome and guides treatment decisions. Advanced imaging techniques, of course, will be the role of horizon CT and PETs. Horizon CT show characteristical perilymphatic nodules along bronchosvacular bundles, while PET-CT is now essential for evaluating cardiac sarcoidosis, activity, and identified focal process sites. Now, what are the typical features of pulmonary sarcoidosis? Of course, will be the lymphadenopathy, most common, symmetrical, bilateral hilar, and right paratracheal lymphadenopathy in 1, 2, 3 signs. Calcification is uncommon. Micronodules, 2 to 4 millimeter, well-defined nodes in perilymphatic distributions. Zonal predominancy, upper and mid-zone predominancy. Peribronchovascular thickening, irregular bronchosvacular bundle thickening. Fibrosis and architectural distortion, upper, low volume loss, and bronchiovascular retraction in common disease, and normally mistake can have Galax signs, central mass-like consolidation with surrounding satellite nodules. And that's how the CT scan really looks based on that descriptions. You see really a diffuse nodules, and most of them you can appreciate here. And you can also look at perihilar and also bronchovascular, and you can see also subpleural, and mostly upper predominate. And if you look at the soft tissue window, you can get to see there, you can appreciate the mediastinal adenopathy. And let's test our fellow. Which sign is this?
That's the galaxy.
And this one? And what's the difference between the two?
So as you said in your previous slide, the galaxy is a consolidated central mass with the satellite nodules. And then on the other image, I see basically a conglomerate of nodules.
Not really. So the third one is, the second sign is what we call cluster signs, but they're not coalescent. They don't form together. So the difference is that one form a joint and the other one is really just a nodule, but they don't really coalescent together. So that's called these clusters, and the other 1, 2, 3, and I've got covalent signs. A typical, less common CT presentation, we have seen quite a lot, and people get embarrassed with diagnosis when sarcoid present with mass-like opacity, called a nodule, forming micronodules like galaxy sign. Cavitations also is very rare, but may occur within nodule or mass-like lesion, and sometimes be taken for what you call squamous carcinoma or TB, or what you call organizing pneumonia. Mosaic attenuation, air trapping with vascular attenuation due to small airway involvement. And then pleural involvement and common pleural thickening or effusion may occur. So that I've seen previously, and this is a typical presentation. You can see quite nodules there with quite a lot of cavitations. Yeah. And then when you look, this is one of my patients that presented to me about 3 years ago with hemorrhagic pleural effusion and diagnosed confirmed sarcoidosis. Role of PET-CT, again, as we mentioned for you, it's really more for cardiac CT. And if you look here, you can see quite a nice lesion there. And you can always target and do a biopsy on that. And also obviously help targeting your therapy. So PET-CT in chronic sarcoidosis detect metabolically active gram-negative inflammations, combine functional and anatomical imaging, identify active disease displayed normal biomarkers or lung function, enable accurate staging and detection of occult involvement, improve visualization of extra-thoracic disease, bone, lung, liver, and spleen, play a key role in cardiac sarcoidosis, include asymptomatic patients. Clinical impact and limitation, of course, guide biopsy site selection and treatment plan, monitors treatment response and disease activity over time, differentiating active inflammation from fibrotic disease. FGC uptake is non-specific and may mimic malignancy. That's the only problems. And diagnostic challenge in sarcoidosis lymphoma syndrome. Sometimes you don't know whether it's lymphoma or sarcoidosis and require cautions regarding cumulative radiation exposure. Of note, you cannot do PET-CT if you have no tissue to confirm. You first need to confirm that the patient got underlying sarcoidosis. If you don't have tissue, you cannot make PET-CT because it just light up like a Christmas tree and you don't know what you're actually dealing with. Role of flexible bronchoscopies, EBUS, which is the latest thing that become for the last 10 years, and transparent biopsy sarcoidosis. It's a diagnostic rationale. Sarcoidosis require histological confirmation of non-casseting granulomas with the exclusion of TB, lymphoma, and fungal disease. EBUS, first-line invasive test for mediastinal or hilar adenopathy, sensitivity to 80 to 90%, superior to blind TPN, and comparable to mediastinoscopy with lower morbidity. Transbronchial biopsy, diagnostic yield of 50 to 70% higher with more than 5 biopsy, and parenchyma disease, complement nodal sampling. Combined approaches, you can use the EBUS and TPN plus transbronchial biopsy, increase diagnostic to 90%, particularly in scattering stage 1 to 2. Safety of profile, EBUS has very low complication rates. Transbronchial biopsy carries small risk of pneumothorax and bleeding. Guideline ATS-ERS recommend EBUS, TPN as a first line with transbronchial biopsy added when parenchyma involvement is present. Bronchoalveolar lavage, finding sarcoidosis. Normally, the common finding is lymphocytosis, which I think you could always go from the bottle up, AMPAT and PATCare. Bronchoalveolar lavage lymphocytes, typical of more than 15 to 25% of the active alveolitis. Elevated CD4-CD8 ratio, usually 3.5, high suggests but not diagnostic. CDT cell predominance, the Th1 polarized alpha T cell drive granuloma formation, and then activated alveolar macrophage, enhance antigen presentation, cytokine release, diagnostic role, supported diagnosis when integrated with clinical and radiological data. Limitation, ratio may normalize in fibrotic or treatment disease. Basically, what it means that if someone got fibrosis already, the disease has switched from M1 to M2, so you don't actually get to see CD4, the ratio actually drops, so sometimes confuse people. Role of calcium and ADC in the diagnosis of sarcoidosis. Pathogenesis, granulomatosis, macrophage, increased calcium production and secrete ACE, reflecting granuloma's burden. Calcium abnormalities, you get hypocalcemia in 10 to 20% and hypercalciuria in up to 60%, supporting supportive of active disease but low sensitivity. Serum A elevated 40-60% of untreated patients correlate poorly with disease severity. Diagnostic value both are supportive markers and cannot confirm or exclude sarcoidosis. Limitation: ACE elevated TB, lymphoma, liver disease, calcium influenced by renal function, and vitamin D intake. Guideline ATS ERS does not recommend ACE or calcium as a stand-alone diagnostic test, useful for baseline assessment and monitoring. Histological hallmark, the granuloma. So granuloma, of course, it will be the microarchitects where you got definitive features in the tight pack, non-casseting epithelial granulomas, core epithelial macrophage, and CD4 T-cell lymphocyte inclusions, of course, asteroid bodies and laminated squamous bodies. Quantity, CD8 T cells and B cell form and naked peripheral lane. So histological findings sarcoidosis for the fellows, of course, we have non-necrotizing granulomas, which tend to be well-formed, tight aggregate of epithelial histocytes, absence of central cases necrosis, characteristic. Multinucleated giant cells, which tend to be longer head types and foreign body, giant cell commonly present, contain cytoplasma inclusions such as squamous bodies and asteroid bodies. Peripheral lymphocytic rim, of course, we have sparse rim of CD4, Th1 lymphocyte. CD4 predominates a direct immune-mediated granuloma formation. Distribution pattern will be granulomas distribution along lymphatic pathway, predilection for peribronchovascular, subpleural, and septal regions. Fibrosis in chronic disease, granulomas may coalescent and be replaced by collagen deposition, associated with architectural distortion and bronchovascular retraction. Exclusion infections, negative acid-base bacillia and fungal stain mandatory. Histology must be interpreted in microbiology and clinical context. So this is a really table that the fellows need to understand the difference between necrotizing granulomas and non-necrotizing granulomatous. So that's who will be. I think you guys must spend time understand the table. It's normal pop up in exams. So the most common feature, of course, will be central necrosis. We see necrotizing granulomas is present because they got cases of fibrinoid materials and absent non-necrotizing. Non-necrotizing is more sarcoid, necrotizing is more really tuberculosis and others. And then common causes are tuberculosis, fungal infections, and GPA, granulomatous polyangiitis. And then the necrotizing will be a sarcoidosis, early disease, and Crohn's disease. Common, of course, with the TB and authors, and the other one's rare. So I think it's better really to have a look at it. And then biomarkers, of course, we say we look at the AC levels, again, which is lack passivity and also elevated conditions like tuberculosis and tumor, followed by interleukin-2 receptors, broader overlapping level with other intestinal lung disease, and then, of course, and then the others really, you just need to know the biomarkers and sarcoidosis. Indication for treatment in sarcoidosis, of course, is life or organ-threatening disease. That would be a cardiac sarcoidosis, neurosarcoidosis, ocular disease, threatening vision, and severe hypercalcemia. And then progressive pulmonary disease, that decline in lung functions, worsening radiology, or progressive fibrotic phenotypes. Significant or persistent symptoms, of course, that's a dyspnea, cough, fatigue, or pain. Okay, and then, of course, extra pulmonary organ dysfunction, that will be hepatic, renal, cardiac, neurological, or cutaneous disease with functional impairment, failure in spontaneous emissions, such as percent active disease beyond 6 to 12 months, especially scandal stage 2 and 3, high inflammatory activities, inflammation, PET-CT with clinical correlations. Prognostic markers, of course, the prognostic marker in sarcoidosis will be lung function decline, reduced FVC and DLCO at baseline, or progressive decline, predict chronic disease and mortality. Radiological staging of fibrosis, horizontal CT evidence fibrosis and traction bronchiectasis and upper lobe volume loss associated with poor prognosis. PET-CT activities, persistent metabolic activity correlated with ongoing inflammation and treatment requirement. Extrapulmonary involvement, cardiac, neurological, and pulmonary hypertension involved strongly predict adverse outcome. Biomarkers, elevated sulfur IL-2 receptors, and persistent hypercalcemia associated with disease activity and chronicity. Clinical cause, failure of remission within 2 years and needed for long-term immunosuppression indicate worse prognosis. Therapeutic escalation later, you have your first line, you have corticosteroid, 20 to 40. And in my practice, I said 20 plus 40 divided by 2 is 30. So I use 30 milligrams. And almost for 6 weeks. Cytotoxic drug will be a methotrexate and azathioprine. And the third line would be your imifliximab. And then, of course, the fourth line would be your JAK inhibitors. Conventional treatment, corticosteroid first line, prednisone, as I said, 30 milligrams with tapering and affected by associated with significant toxicity. Long-term clinical outcome, of course, with the treatment prognosis, you get 60% spontaneous remission, 25% chronic persistent disease, and 50% progressive or fibrotic. Steroid-sparing agent, methotrexate, most evidence at that, and then azathioprine, and lipidamide, and of course, mycophenolate mofetil. Mechanism of action of methotrexate, I think is very, very important to understand. It's adenosine-mediated anti-inflammatory effects. Methotrexate inhibit AICAR transformylase and results increase in AICL accumulation. And you get extracellular increase in extracellular adenosine and reduction in TNF-alpha, interferon gamma, which is inflammatory cytokines, and reduce glomerular inflammation. And part 2, of course, it's also got antimetabolic effect on lymphocyte. Methotrexate also inhibit the dihydrofolate reductances and result in decrease in tetrahydrofolates, decrease in purine and pyrimidine synthesis, decrease in DNA replication, decrease in T cell proliferation, suppression of cytoimmune response. Biological therapies are TNF-alpha inhibitors, affected respiratory disease, high infection risk, careful selection requirement, and make sure you exclude latent TB. Besides medicine and physiotherapies, of course, that would be the mTOR receptors, sirolimus, JAK inhibitors, and of course, an omics-driven treatment stratification. This is quite a novel immunomodulator targeting neutrophil 2-mediated immune regulatory. It's a phase 2/1b/2a randomized trial show reduction in corticosteroid dose, improvement in FVC and patient reported outcomes, favorable safety and tolerability profile, and now currently in phase 3 randomized control trial ongoing pulmonary sarcoidosis, designed specifically as a steroid-sparing therapy, represent the most advanced novel agent sarcoid trials. Those you can take quite article in the new journals, European respiratory journals. Antifibrotic therapies, of course, one which is currently being studied in sarcoids will be the progressive, those with the progressive fibrotic sarcoidosis, for example, progressive pulmonary fibrosis. Antifibrotic will be nintedanib, pirfenidone, proved in non-IPF producing ILD. And the trial was inbuilt trial, support antifibrotic use in progressive fibrotic phenotypes. Sarcoidosis-specific trials are explanatory and ongoing. Potential role in advanced fibrotic sarcoidosis, evidence currently explorating, not diagnostic specific. JAK inhibitors, again, is one of the things, as I mentioned. I think for fellows, you guys can go through the slides. And metformin also is having roles in patients that are on the steroids. So it's a non-immunometabolic and anti-inflammatory effect, ongoing randomized controlled trial in steroid-dependent sarcoidosis, because the sarcoids are really steroid-dependent, and to limit the glucose side effect, I think better to give the patient metformin. Primary outcome was reduction in steroid requirement, secondary outcome, lung function and symptom burden, attractive due to low cost and safety profile. Results are pending. So what's the key take home for sarcoidosis? Sarcoidosis heterogeneous and multisystemic disease, diagnosis remain problematics, treatment is increasing, individualized, precise medicine hold future promise. References, ATS typhoid guidelines, Lancet, thoracic, blue journals. And yeah, thank you.
Thanks, Dr. Taban. Is there any questions?
The sarcoidosis generally affect the lungs.
Yeah, well,
As a hematologist, I've studied, how it can affect the spleen and the bone marrow.
everywhere else. It's a multi-systemic disease normally. Any organ, lymphatic organs can be affected with sarcoidosis, but predominantly organs will be in the lungs, and then of course, and then your lymphatic system.
So it'd be unusual for it to present with just bone marrow sarcoidosis.
It can, yes, it can.
It can, but
Yeah.
it's not the usual. So it's usually
Well, look, it can present with bone marrow. Of course, it depends on a pulmonologist. And then sometimes when you look, then you find that organs actually affected. Yeah. So normally once you pick up, sometimes they present just with a skin lesion. But when you look at this, always lung involvement, either as in form of adenopathy or actually stage 2 with the lung parenchyma involvement. Yeah.
So if I understand you correctly, you're saying sometimes the lung involvement is more subtle and
Yeah.
sometimes picked up elsewhere.
Yeah, exactly. Yeah. So you can sometimes pick up from other organs. Sometimes just ophthalmologists pick it up because when they pick up visual problems, and then when they go looking, then they find actually there's lung involved.
Okay, thank you.
I just want to find out, so the serum ACE, do you use that for diagnosis or for monitoring?
Monitoring.
Monitoring.
Yeah. Because if it's low, it does not exclude sarcoidosis. So it's just for monitoring. No matter after when you initiate therapy, you do baseline, then of course you need to have monitoring part of it. Yeah.
So what do you do for patients that's on an ACE inhibitor? A lot of the patients are on.
No, there's no relation between the two.
No.
Yeah, no. ACE inhibitors really, but you still have, because the sarcoid does produce ACE. Actually, I haven't looked into that actually. Yeah. Because
Because a lot of patients have
Yeah.
hypertension and are on
Yeah.
ACE inhibitors.
think-
So
I think I need to look into that. But ideally, it's really not reported in literature, and perhaps maybe because we haven't looked into it. But I think shouldn't be, because remember, the ACE inhibitors really, the ACE will be normal, but in effect, actually, the target where the ACE actually on the ACE itself, it doesn't affect the conversion of ACE. I remember, so I'll have a look at it and come back to that. Homo?
Thank you.
What is a word? Okay, let's summarize. What's the time? 7. Yeah, okay, great. Can we call this a day? Thank you. Any question online? Did I close? I think I can come out.
Just
Yeah. Anybody online? Oh, there. Yeah, there we go. Yeah, there.
And no question from my side. Great presentation.
Thank you. Is Amanda Jordan? Okay. Doani,
No question, Dr. Taban. Thank you very much for the presentation.
I have a question for you then.
Oh, okay.
So,
What's the question?
what's the difference between the bronchoalveolar lavage in patient with sarcoid and HB finding?
Okay. So the difference will be the lymphocytosis. So both will have lymphocytosis. While with sarcoidosis, the predominant lymphocyte is CD4, while in HP is CD8. So the CD4-CD8 ratio in sarcoidosis will be more than 3.5, while in hypersensitivity pneumonitis will be less than 1 because it's predominantly CD8.
Thank you.
Thank you.
All right. If there's no questions, can we call it a day?
Also, I just want to ask, if you want CPD points, you can just in the chat box put your name and your MP number, please. Then we can add it for CPD points for you guys.